Thank you very much, and it's a delight to be able to present what I think are some exciting results from a small oral molecule. I'm going to present the results of a proof of concept phase 2 study, the SHINE study, of this molecule CT1812 in mild to moderate dementia due to Alzheimer's disease. And I'm going to focus on pre-specified low phospho-tau 217 group. This is plasma phospho-tau. These are my disclosures. I was a principal investigator in the phase 1 and the phase 2 trial. Now, we know that plasma phospho-tau 217 is a predictive biomarker of response to therapy. It reflects brain amyloid and tau burden. Prior data have indicated that individuals with lower AD pathology at baseline, as reflected by lower levels of plasma phospho-tau 217, have a greater response to amyloid-based therapies. For instance, in the donanemab Trailblazer 2 study, those in the lowest tertile of phospho-tau plasma had a 38% slowing compared to 21% in those in the higher tertile. Now, given that this molecule's mode of action is displacing A-beta oligomers, we hypothesised that larger treatment effects could be observed in participants with lower plasma phospho-tau at baseline. And this was a pre-specified subgroup analysis. The proposed mechanism of action of CT1812 is a first-in-class sigma-2 receptor modulator. Preclinical and clinical evidence shows that this acts to displace the A-beta oligomers from synapses, and this facilitates clearance of the A-beta oligomers in the CSF. The proposed synaptoprotective mechanism of action slows neuronal injury and loss. And this mode of action is distinct from the anti-amyloid immunotherapies. On the right there, you'll see a diagram showing A-beta not able to bind to its receptors because of the purple-coloured sigma-2 receptors being influenced by this small molecule shown in green. The phase 2 proof of concept study is summarised here. These were all patients who were positive for amyloid, either on CSF or on amyloid PET scan. MMSE reflected the mild to moderate stage of the disease, 18 to 26. The treatment period was 6 months either of 100 or 300 milligrams of the investigational product or the placebo. And there were 153 participants. You'll see the key objectives on the right, including cognitive and functional endpoints, but we're going to look at the pre-specified subgroup analyses based on plasma phospho-tau 217. So these are the groups. On the left column, you'll see the modified intention to treat whole group analysis. In the middle, you'll see the low phospho-tau, and on the right, you'll see the high phospho-tau. Essentially, the baseline phospho-tau plasma phospho-tau levels were arraigned and a cut line put in the middle, and this led to the median being 0.66 picograms per mil for the low group and 1.53 picograms per mil for the high group. The baseline characteristics didn't differ much, perhaps a slight difference in the use of cholinesterase inhibitors in the slightly more advanced disease group as defined by plasma phospho-tau and as would be expected. In terms of safety and tolerability, these have been presented earlier this year at AIIC 24, and it demonstrated a generally favourable safety and tolerability profile. Adverse events between placebo and the investigational product didn't differ significantly, nor did serious AEs. In fact, they were in favour numerically of the investigational product, and there was only one death in the placebo group. Most treatment-emergent effects were mild or moderate in severity, and there were no discontinuations due to adverse events in the 100 milligram dose group. Most discontinuations were in the 300 milligram dose group, and there were some reportable liver enzyme elevations in that group, suggesting that maybe a lower dose could be used for further studies, but that's yet to be decided. Now, what about the impact on exploratory outcomes? Let's look at cognition and function. So here's the ADAS-Cog 11. On the left, you've got the modified intention to treat population. You'll see a tendency for a better effect, a lower rate of decline in those on the investigational product as opposed to those on placebo, but it was not statistically significant. However, if we look at the low tau group in the middle there, in the boxed area, you'll see in the 69 patients that were in that low tau group, a very significant difference between deterioration in the placebo group and almost a failure to deteriorate. In other words, baseline levels of ADAS-Cog11 at week 26 compared to the baseline level in the low phospho-tau group. And what's more important perhaps is that these lines seem to be continuing to separate, suggesting an ongoing disease-modifying effect. On the right, you'll see that in the high plasma phospho-tau group, there was no difference between the patients treated with the investigational product and those on placebo. So this is a very significant finding, suggesting that those with lower phospho-tau had an improvement in this exploratory cognitive endpoint, the ADAS-Cog11. MMSE, similar. We've got the total modified intention to treat population on the left. Again, a tendency for benefit from the investigational product compared to placebo at week 26. But on the right, in the low tau group, you'll see the MMSE virtually didn't change, in fact slightly improved in the treatment group compared to the placebo group. And on the functional endpoint, the ADCS-ADL, you'll see virtually no decline in the low tau group compared to placebo. And in the overall global measure, the CGIC, there was less decline in the low tau group treated with the investigational product compared to placebo. So the summary and conclusions were that baseline plasma phospho-tau 217 seems to identify a strong treatment responder group. It's generally safe and well tolerated, and the modified intention to treat showed favourable trends in those treated with the investigational product. An optimal dose range has been identified, and there's a large cognitive impact observed in pre-specified below median plasma phospho-tau subgroups in the exploratory endpoints. The limitations, of course, is there's smaller sample sizes when you break the group into two, and exploratory outcomes are hypothesis generating and need to be confirmed in larger studies. There's an attempt, therefore, to assess this in a larger study, a phase 3 study. It seems to be logical to proceed that way. Whether the low phospho-tau is used to, again, stratify people, or whether only people with lower phospho-tau are included in the study, the proposed phase 3 study, has yet to be defined. But I think we are excited by the potential of this first-in-class oral investigational product to have beneficial effects in mild to moderate Alzheimer's disease. Additional data can be obtained by scanning the QR code seen on the right there. I'd like to thank, firstly, the investigators, the National Institute of Aging for funding, the SHINE participants, their care partners and family members, and also Cognition Therapeutics, the sponsor of this trial. Thank you for listening.
Questions for Dr. Woodward? Let me ask one question. You're suggesting that lower pathology might favor a group that would be responsive to the treatment. Why not choose clinically milder individuals?
We're suggesting that lower pathology, which may be indicative of an earlier stage of the disease, defines response. And I think the tendency with many products is to move to earlier and earlier stages, but we still do need small molecules for the more advancing stages of Alzheimer's. I don't think we should ignore those people who have moved into the MMSE 20 or below group. But we're not sure whether this is just disease modifying or symptomatic or both. So I think it's still justified to continue to include those in the more advancing stages of the disease and not put all our energy into the almost preclinical stages of the disease.
Thank you. Any other questions for Dr. Woodward? I don't see any. Okay, thank you.